Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this QME Home Study Continuing Education program. This is the 8th in a series of programs presented by www.ezqmeceu and myself. And today's program is on manual muscle testing and the AMA Guides 5th edition. And I want to explain what you're going to receive in this program. Today I'm in the studio and I'm actually recording a PowerPoint presentation on today's topic, manual muscle testing. Now, some of you do not have PowerPoint. That's okay. For those of you that do not have PowerPoint, I've included along with this program a copy of the PowerPoint slides. So if you're listening simply to the audio program, you can follow along with the handout materials that I've given you, which are simply copies of the PowerPoint presentation. And if you do have PowerPoint, I encourage you to use the PowerPoint presentation because the program flows very nicely, just as if you were at a live lecture. And PowerPoint has really come a long way, and it allows us to do a lot of teaching within the program. So the PowerPoint presentation is actually the enhanced program, but that's okay if you do not have PowerPoint. You'll still be able to easily follow along with the handout materials that I've given to you. And I will make reference to those handout materials as we go along here. Okay, so let's get started with today's program. Today's program is entitled Manual Muscle Testing and the AMA Guides 5th edition. And we're going to use the abbreviation MMT to indicate manual muscle testing. And the reason I created this program was because I found throughout the AMA guides, especially in chapters 15, 16, and 17, that there are references to manual muscle testing in the determination of permanent impairments, but I found that the AMA guides were lacking in terms of giving us a description of the procedures for performing manual muscle testing. And in discussing this with my colleagues, I found that there were as many different methods of doing manual muscle testing as there were colleagues willing to share with me their opinion or their idea as to what it is that the guides mean when they refer to manual muscle testing. So I felt that it was necessary and important to come up with some standardized criteria, and that's what I'm going to share with you throughout this program. In part 1 of the program, we're going to go through the AMA guides, and we're going to open up chapters 15, 16, and 17, and I'm going to show you the references in those chapters that the guides make to manual muscle testing. And each of the chapters has both some features of manual muscle testing and the grading systems associated with manual muscle testing. Some of the features are similar from chapter to chapter, and some of the features and grading systems are different from chapter to chapter, and I'll point those out to you. Once we've established that the AMA guides do require us to perform and be proficient in manual muscle testing in chapters 15, 16, and 17, once you're convinced of that, we're going to get into some important considerations regarding manual muscle testing and some important considerations regarding muscles in general. And I begin that discussion with what I call myology 101, the development of the muscular system. So we're going to go all the way back to the beginning, to the embryo, and find out how muscles are formed in the first place and how those muscles partition themselves out into muscle groups of both the upper and lower extremity. And I'm sure you'll find that to be a discussion that shakes loose some dormant synapses, probably from years or even decades ago. Then in part 2, once we establish some general principles about muscles, then we're going to get into some general principles and procedures about manual muscle testing specifically. And once we establish some general principles for how it is that we actually do manual muscle testing, we're then going to get into some specific tests for first for nerve root innervated muscles, in other words, muscles innervated by spinal nerve roots, and this comes out of chapter 15. And you'll note that when we get to that portion of the program, manual muscle testing of nerve root innervated muscles focuses on testing of specific muscles. For example, we're going to be talking about the deltoid muscle and the bicep muscle and the extensor carpi radialis muscle and all these specific muscles, whereas later on when we get into manual muscle testing of peripheral nerve innervated muscles, we don't so much focus on specific muscles as we do focus on specific motions. So, for example, in chapters 16 and 17, we focus on movements of shoulder flexion and shoulder abduction. And in the lower extremity, we focus on movements such as hip flexion and movements such as knee extension. So the guides alternate between manual muscle testing of specific muscles and specific motions, and I'll point those out when we get to those specific references in the chapters. And then at the end of the program, we're going to review our QME templates, and I'm going to provide for you some templates that you can import into your report template for reporting the findings of your results on manual muscle testing. And that should pretty much bring us around to the 6-hour mark. Now, before we get into all that stuff, I just want to go over a brief history of manual muscle testing itself and apply that history to the AMA Guides 5th edition. According to the research that I was able to uncover, manual muscle testing goes back to about as early as 1912, when Dr. Lovett, a professor of orthopedic surgery at Harvard Medical School, first used manual muscle testing. It was written about in 1912, not by Dr. Lovett, but by one of his assistants who described some of his procedures in a written manuscript in 1912. Dr. Lovett himself first published articles about his findings on manual muscle testing in 1932. And Lovett was the first to establish a muscle grading system wherein he described 5 levels of muscle strength against gravity and or resistance. And we'll talk about the role of gravity in manual muscle testing here as we go. Later in 1936, Kendall and Kendall, some physical therapists, they developed a percentage scale for rating and grading muscle function. And the Kendalls, I should say, are quite famous in the world of manual muscle testing. When I was in chiropractic school in the early and mid-1980s, we used the Kendall and Kendall 3rd edition of Muscles, was the name of their textbook. I now have the 5th edition, which is the most recent edition by the Kendalls, and I believe the 5th edition was published in the early 2000s, perhaps 2005. I have that textbook, but it's not on my desktop right here as we speak, but I think it was published in 2005. So their work continues on now almost, what is that? 60, 70 years their work continues. Then in 1945, Daniels and Worthingham, they came along and they developed also a numeric rating scale for describing muscle function. And then in the 70s, the Medical Research Council of the United Kingdom, not the United States, but the United Kingdom, became the authority on grading muscle testing and describing muscle function. And we're going to see that the AMA guides alternates between all of these systems. At certain points in the guides, they use the Medical Research Council grading scale. At other points in the guides, they use the percentage scale as described by Kendall and Kendall. And even in other parts of the guides, they use the five numeric grades first described by Lovett as early as 1932. And I'll point those out, and we will discuss in more detail the various types of grading systems described in chapters 15, 16, and 17 of the AMA guides. The Lovett scale uses letters to describe muscle function, ranging from absolutely no muscle function, meaning a totally paralytic muscle, which is graded letter 0, or I guess that's numeral 0, all the way up to normal muscle function, which is given a letter grade of N. And grades in between 0 function and normal function would include T for trace function, P for poor function, F for fair function, and G for good function. And we're going to see that at least for some of those grades, for example, the grades of poor, fair, and good, we can also assign a plus or minus sign to indicate greater or lesser degree of function than what we would expect for the standard grade. The Kendalls described a percentage scale that corresponds with the Lovett scale. The Kendalls used numeric percentages. For example, with the Lovett scale, we use numeral 0 to indicate a totally paralytic or dysfunctional muscle with no sign of muscle contraction. Well, the Kendalls gave that a 0% score. And whereas the Lovett scale gives a grading of N for normal muscle function and normal muscle strength, the Kendalls described that as a 100% score. And percentage scores in between 0 and 100 that correspond with the Lovett scales include 10%, which is equivalent to a Lovett scale of T for trace contraction found in a muscle. 25% corresponds to the Lovett scale of P for poor muscle function. 50% corresponds to the Lovett scale grade of F for fair muscle function, and 75% corresponds to the Lovett scale of G for good muscle function. And you'll notice in between these large ranges of percentages, for example, from 10% to 25% to 50% to 75% to 100%, you could also describe intermediate ranges such as 60% or 65%, which would correspond with the plus and minus signs allowed by the Lovett scale. And then finally, the Medical Research Council of the United Kingdom uses a 6-number scale ranging from 0 to 5 to represent the range of muscle function from no contraction of the muscle, which is assigned a grade of 0, all the way up to full muscle function, which is assigned a grade of 5. And so we have these 3 different scales, the Medical Research Council scale, and we have the Kendall scale, and we have the Lovett scale. And really, they can be used almost interchangeably. However, each one allows for certain latitudes in assigning for grades of muscle function in between the standard grades. And each one of them carry with them specific definitions. So, for example, whether we're talking about the Medical Research Council grade, or the Kendall percentage grade, or the Lovett scale grade, regardless of the system that we use, a grade of 0 all indicate the same thing. Grade of 0 indicates that we have here a muscle that has no evidence of contraction. Now, what kind of evidence do we see when we have a muscle contraction? Well, we can both see a contraction and we can feel a contraction. So when we have a grade of 0, we have no visible evidence of contraction and no palpable evidence of contraction. When we have a grade of 5 on the Medical Research Council scale, or a grade of 100% on the Kendall scale, or a grade of N on the Lovett scale, what we're talking about is we're talking about a muscle that is capable of taking the involved joint through full active range of motion and against full resistance. Now, the resistance is applied by you, doctor, and so it's up to you to decide what qualifies as full resistance, and that's going to vary based upon several things. Number one, that's going to vary based upon which particular joint it is that you're testing. For example, you're going to be able to apply much more pressure to resisted knee extension as you would apply to resisted wrist extension. Okay, but they could still qualify for grades of 5 if they demonstrate full function. Also, it's going to vary based upon the sex of your examinee, the size of your examinee, and many other factors, and we'll get into those here as we go. So we're going to be alternating amongst these various different scales, and the AMA guides use all of these scales at various points throughout chapter 15, 16, and 17. Now, you might be wondering how reliable is manual muscle testing, since there is some subjectivity involved in manual muscle testing. There's subjectivity on the part of the examinee, and there's subjectivity on the part of the doctor. And as I mentioned previously, when it comes to examining different people and different joints, you can imagine that there's a lot of variability that introduces itself into the procedure. Well, it has been found that manual muscle testing, when it's properly performed, is actually quite reliable. And it's especially reliable for the intermediate grades, the grades of 2, 3, and 4 on the Medical Research Council scale, which would be similar to the grades of trace, poor, and fair on the Lovett scale. And so it's extremely accurate, and it's been found to be accurate at least within 1 grade, both within examiners and between examiners. So what that means is, if we have an injured worker or an examinee, let's say, and the same doctor comes and tests a specific muscle, let's say for example the deltoid muscle, on 2 separate occasions, that doctor will usually come up with the same grading, at least within 1 grade, plus or minus, on both occasions. Similarly, if 2 different examiners come along and test the same examinee, they will generally come up with the same grading within plus or minus 1 grade. And accuracy on manual muscle testing is easy to imagine once you fully understand what the definitions of the various grades mean. And we're going to see that the most pivotal grade to understand the definition of is the grade 3. So keep that in mind, and we'll elaborate on that here in just a moment. For now, let's move into the AMA guides, and if you have your guides, you can pull them out, and I'll make reference to specific tables. If you're watching the PowerPoint presentation, I have those tables for you here, already pulled out and copied here on our slides, so you can follow along on the PowerPoint presentation. In Chapter 15, Table 15-16 is entitled Determining Impairment Due to Loss of Power and Motor Deficits. And we determine permanent impairment due to loss of power and motor deficits with manual muscle testing. And in Chapter 15, we suffer losses of power and motor deficits when we have injury to either spinal nerve roots and or the spinal cord. Chapter 15 is all about the spine, so we're talking here about injury to the spinal cord and or spinal nerve roots that then results in a loss of motor power and motor deficits. So Table 15-16, you'll notice, is divided into 3 columns. And each one of the columns uses a different grade to describe our findings on physical exam. For example, if we have an active movement against gravity with full resistance, in other words, we have an active joint movement, and what is it that moves joints? It's muscles. If we have an active joint movement against gravity with full resistance, and it's up to you, doctor, to establish what full resistance for that particular joint is, then we grade that as a number 5, full muscle function, and we say that that muscle has a 0% motor deficit. So here we're using both the Kendall scale and also the Medical Research Council scale within Table 15-16 of the AMA guides. So what's important is the definition or the description of muscle function. We have an active movement against gravity with full resistance. So our forces here opposing the movement are, number 1, the full resistance as applied by the doctor, number 2, gravity as applied by the gravitational pull of the earth, and number 3, the weight of the limb or segment being moved. 3 items, 3 components opposing the pull of the muscle. And when that muscle is able to sustain pressure against all 3 of those components, we describe that as a grade 5 full muscle function with 0% motor deficit. When that limb or segment is able to produce an active movement against gravity with only some resistance, in other words, not with full resistance, we grade that as a grade 4. And the AMA guides ascribe a 1 to 25% motor deficit. And notice that there's a large range there. And doctor, it's up to you to describe where in that range your patient scores or grades. And then it's up to you to justify or substantiate why it is that they qualify for a 5% motor deficit or a 10% motor deficit or a 15% motor deficit versus a 20 or 25% motor deficit. And we'll talk about that a little bit more as we go. A grade 3 muscle function is when we're able to produce an active movement of the limb or segment against gravity only without added resistance by the doctor. Now, grade 3 is assigned a 26 to 50% motor deficit, and again, there's a large range. Now, the grade 3 muscle grading is the critical pivotal grade, because for grades above grade 3, such as grade 4 and grade 5, we see that the limb or segment is able to sustain resistance. A grade 4 involves some resistance, a grade 5 involves full resistance, but a grade 3 is an active movement against gravity only with no resistance. So that tells you right there your very first step in assigning the appropriate grade, and this explains why manual muscle testing has very high intra-rater and inter-rater reliability, is because your very first step is to establish whether or not your examinee can move against gravity. If they can move against gravity, then they at least are graded, or that muscle is at least graded a grade 3. If you're then able to add some resistance, then we get up into the grades of 4 or 5, and you can decide which of those to use. 3 is the pivotal grade. Now, a grade 2 is when we have an active movement of the limb or segment, now with gravity eliminated. Now with gravity eliminated. Here we are eliminating the weight of the limb. Well, how do you eliminate the weight of the limb? Those are movements that have to be performed in the horizontal plane with the limb supported, such as sliding across the top of a table, a horizontal movement versus a vertical movement against the pull of gravity. Okay, so if your examinee can move against gravity, that's a grade 3. If they're not able to move against gravity, then that's below a grade 3, and it's up to you to determine whether it's a 2 or a 1 or a 0. If you eliminate gravity and they are able to complete some active movement, then that qualifies as a grade 2. That's a 51 to 75% motor deficit, and then it's up to you to decide where in that range they qualify, depending upon how much of the range of motion they can complete. Finally, grades 1 and grade 0 represent very little muscle function. A grade 1 is when we have a very slight contraction of the muscle, either a visible contraction or a palpable contraction. However, there is no movement of the limb or segment. And then finally, grade 0 is when there's no visible or palpable contraction of the muscle. That qualifies as a 100% strength deficit. So it's very interesting. We're starting to see that the grading system, which is a 0 to 5 system, allows for pluses and minuses within the grades of 2, 3, and 4. And that's consistent with the percentage scales, which describe large ranges of motor deficits, generally in the range of 25 percentage points for each of the numeric grades. So the AMA guides uses a variety of different descriptions, but they actually say the same thing and give the doctor great latitude in assigning the appropriate grade to the muscle or movement tested. In Table 15.2, we get some idea as to which of the muscles Chapter 15 requires that we test. For the lower extremity, we're going to be concerned with the quadriceps muscles. We're going to be concerned with the extensor hallucis longus muscle, and we're going to be concerned with the ankle plantar flexor muscles, because those muscles are innervated by the important nerve roots L4, L5, and S1 that we would commonly see involved with a spinal injury. In the cervical spine, we're going to be concerned with the deltoid primarily as a reflection of the function of the C5 nerve root. We're going to be concerned with the biceps as related to C6 nerve root, the wrist flexors related to the C7 nerve roots, finger flexors related to the C8 nerve roots, and the intrinsic hand muscles, meaning the palmar adductors and the dorsal abductor muscles of the hand, as a function of the T1 nerve roots. And those are the exact muscles which we will describe later on in the program, and we'll go over the manual muscle testing procedures for those exact muscles, because those are the ones that are required by Chapter 15. In Chapter 16, Section 16.8c on page 509, we get a description of what Chapter 16 considers to be key grades for grading your findings on manual muscle testing. And it says there on page 509 as a quote, it says, "Manual muscle testing assesses an individual's ability to, number one, move a joint through a full range of motion against gravity, or 2, move it against additional resistance applied by the examiner, and or number 3, hold the joint position against resistance." So therein lies the crux of our grading system. Number 1, and that is, can the limb or segment be moved against gravity? If so, it's at least a grade 3. If it can be moved against additional resistance applied by the examiner, then it's at least a grade 4 or 5. And if the joint can be held, if the muscle can hold the joint position against resistance, again, that's a 4 or a 5. And those are the most common grades that we're going to see as qualified medical evaluators, is grades 4 and grades 5, with possibly occasionally a grade 3 in the event of serious and prolonged radiculopathy or prolonged spinal nerve root injury. Or as regards Chapter 16, a prolonged or serious peripheral nerve injury. Now, when we do manual muscle testing, we need to be aware that there are many different types. There's 3 different types of muscle action and muscle contractions. We have concentric contractions, where there is a muscle shortening action. We have eccentric contractions, where we have lengthening muscle actions. And we have isometric contractions, where the muscle length does not change. And depending upon which muscle we are testing, we may use one, the other, or even a combination of these different types of muscle contractions. For example, with reference back to that quote on page 509, where it says, manual muscle testing assesses an individual's ability to, number 1, move a joint through a full range of motion. That involves concentric muscle contractions. Well, what about when we hold the joint position against resistance? That is an isometric contraction. And there may be times when we even utilize eccentric muscle contractions. So the AMA guides not only use a variety of references for the grading of muscle weaknesses, they also use a variety of different methods of doing the manual muscle testing procedures themselves. Now in Table 1635, the AMA guides give us references to manual muscle testing for injury to non-neural structures. Non-neural structures. In other words, Table 1635 uses a numeric scale to rate loss of strength, and they call it strength deficit, due to injury to the shoulders and or the elbows. And it's my opinion that this would also apply to the wrists. If you wanted to utilize this table by analogy, it could also apply to the wrists. And you'll notice that here in Table 1635, they use strength gradings or gradings of strength deficit pretty much consistent with the Kendall numeric percentage scale. This is different from the Medical Research Council scale of the 5 to 0 scale. Here we're using a percentage scale to describe loss of strength of specific motions of both the shoulder and the elbow. And Column 3 describes strength deficit of from 5 to 25%. That sounds to me like a grade 4. Or Column 4 describes strength deficits ranging from 30 to 50%. That sounds kind of like a grade 3. So even though this table doesn't specifically correlate these percentage losses to the Medical Research Council scale, they roughly describe the same things. But in this particular table, they use the percentage scale. So throughout chapters in 15 and 16, we're seeing mixing of several different types of scales, but just keep in mind that they're basically saying the same thing in describing whether or not the joint can move through range of motion, whether or not it can hold that position against gravity, and whether or not it can hold that position against gravity plus added resistance. So for example, excuse me, a rating of 0 to 25% loss or 0 to 25% strength deficit would be equivalent to Medical Research Council scale of 5 if we're talking about a 0% strength deficit, or a 4 if we're talking about a 1 to 25% strength deficit. A rating of 30 to 50% would be equivalent to a grade 3 on the Medical Research Council scale. So what does that mean? Well, you would expect to see a person with a 30 to 50% strength deficit. They would have active range of motion against gravity only without added resistance. That would be roughly equivalent somewhere to between a 30 to 50% strength deficit. Well, what would a 40% strength deficit look like? How would you expect that muscle to test? Well, they would have active range of motion against gravity, but maybe now they'd be able to tolerate just a little tiny bit of resistance. Or at certain positions of the range of motion, they might be able to tolerate some resistance, while at the end range of motion, they could tolerate no resistance. In other words, a strength deficit of 40% is improved over a strength deficit of 50% in that the examinee is able to move throughout range of motion with increasing amounts of added resistance. And it's up to you, doctors, to estimate that percentage of strength deficit, and you need to substantiate in your report how it is that you grade a person at some of those intermediate grades. And you could be prepared for some questions on your grading system if you don't substantiate those opinions in your report. Okay, so there's a couple of notable facts about Chapter 16. Number one, I pointed out in Table 1635 that manual muscle testing only applies to injuries involving the shoulder and the elbow. Well, it's my opinion that by analogy, you could also use Table 1635 to describe strength deficits with the wrist. Well, what about the hand? Well, the AMA guides pretty much relies on the findings on grip strength examination to assess for strength losses in the hand. But at least as far as the wrist is concerned, I have used Chapter 1635 to rate by analogy before, and it's gone over without objection. Wrist and hand strength is assessed with grip strength, and we use Table 1635 for the shoulder, the elbow, and even by the wrist. And also Table 1635, you'll notice that Table 1635 applies to testing of specific motions rather than to testing of specific muscles. Now in Chapter 15 we were involved with testing specific muscles, and I described those muscles. We had the deltoid, the biceps, we had the flexor carpi radialis, the flexor digitorum superficialis, and all those that were described in Chapter 16. Here in Chapter 15. Here in Chapter 16 we're testing specific motions. So for example, Table 1635 describes shoulder motions such as shoulder flexion, shoulder extension, shoulder abduction, shoulder adduction, etc. What muscles are involved with the specific motion of shoulder flexion? What muscles are involved with the specific motion of shoulder flexion? Let me ask you. Well, it's multiple muscles. Multiple muscles. You got your anterior deltoid, you got your coracobrachialis, got your long head of the biceps, right? There's several muscles involved with shoulder flexion. We're not testing individual muscles here in Chapter 16. We're testing individual motions, because Chapter 16, at least Table 1635, is concerned with injury, not to neural structures, but to extremity structures, such as shoulder injury. Imagine a contusion injury to a shoulder. We're rating loss of strength of the shoulder in specific motions rather than with specific muscles. And that makes Chapter 16 different from Chapter 15. Well, what about for injury to nerve structures in the upper extremity? For loss of strength and motor deficit due to nerve injury, we use Table 1611. Table 1611 is entitled Determining Impairment of the Upper Extremity Due to Motor or Loss of Power Deficits Resulting from Peripheral Nerve Disorders based on individual muscle rating. And I created an entire program. It's entitled The Upper Extremity Impairments Due to Entrapment Neuropathies to describe permanent impairments due to peripheral nerve injuries of the upper extremity. For this program here today, we want to review the manual muscle testing component of determining the permanent impairment due to loss of motor power. And for that we use table 1611. And notice again that table 1611 uses the 0 to 5 grading scale. It uses the 0 to 100% scale. It also uses the descriptive scale. So let's review these very quickly. Again, the key pivotal grading scale to be familiar with is the grade 3. And that is, with a grade 3 scale, we have a muscle that's able to complete active range of motion against gravity only, without added resistance. If we're able to add additional resistance, then we have grades of 4 and even grade 5, depending on how much added resistance that joint is able to tolerate, that joint or muscle is able to tolerate. Below a grade 3, we have decreasing ability to move the limb or segment or joint against gravity. So with a grade 2, we have movement, however gravity must be eliminated. With a grade 1, we have some evidence of slight contractility of the muscle without joint movement. And then a grade 0, we have no evidence, no visible or palpable evidence of any joint contractility. Okay, in chapter 17, same type of philosophy prevails. In section 17-2E, we use table 17.7 to grade the loss of muscle strength due to injury to non-neural structures, such as injuries to joints, muscles, ligaments, tendons. In other words, non-neural structures. We use table 17.7, and for injury to peripheral nerves, we're going to use a different table altogether. So let's take a look at table 17-7. Table 17-7, you'll notice, incorporates only the 0 to 5 scale. Does not use the percentage strength deficit descriptions that we have in chapter 16. But it's my opinion that you could use the percentage strength descriptions the same way that chapter 16 does if you wanted to do that by analogy. Table 17.7 uses only the 0 through 5 scale, but it's my opinion, and I have done this in my reports, is that I've incorporated the percentage strength deficit when necessary. So in chapter 17, the same descriptions apply. A grade 3 involves active movement against gravity only with no resistance. Grades higher than grade 3 involve active movement against gravity with added resistance. Grades below grade 3 involve decreasing amounts of movement even in the absence of gravity. And a grade 0 includes no evidence, no visible or palpable evidence of any kind of muscle contraction. Now, table 17.8 tells us which specific motions we're going to be testing with lower extremity injury to muscles, ligaments, joints, in other words, non-neural structures. And notice that 17.8 does not describe any specific muscles. It describes only specific motions. I find this incredible that we alternate between testing specific muscles and testing specific motions. And I want you to take a close look at table 17.8. If you have the PowerPoint presentation, this will be easy to do. If you don't have the PowerPoint presentation, make sure that you're looking at table 17.8. Now notice that this is an impairment chart, and so the grade 5 or normal function is not included in this table because that does not qualify for permanent impairment. However, a grade 4 does. So a grade 4 would be equivalent to 1 to 25% loss of motor function of all these different motions. For example, loss of hip flexion strength, loss of hip extension strength, loss of hip abduction strength, etc. Now, if you're looking at table 17.8, notice that the highest impairments are for deficits of hip abduction, which qualifies for 10% whole person impairment due to 25% strength deficit. Ankle plantar flexion qualifies for 7% whole person impairment for 25% or grade 4 strength of resisted ankle plantar flexion. Grade 4 hip extension qualifies for 7% whole person impairment. These are substantial impairment percentages, especially if you think about the spinal categories, the DRE 2 category, which qualifies for 5 to 8%. Here we're seeing impairments in the range of 7 and 10% for only 25% loss of strength in these specific joint motions, the highest of which is loss of strength of hip abduction. So this gives us an idea as to what the AMA guides consider to be important joint functions. And I want to just compare some of these impairment percentages to amputation as described in table 17-32. So we see here in table 17-8 that a 25% loss of strength of hip abduction qualifies for 10% whole person impairment. Compare that to a hip disarticulation in table 17-32, which qualifies for 40% whole person impairment. Okay, so if your hip, if you lose your leg at the hip joint, that's a 40% whole person impairment. Well, here a 25% or grade 4 muscle strength of hip abduction qualifies for 10%. That's a substantial impairment percentage, and that gives us an idea of how important the AMA guides consider normal hip abduction strength to be. Similarly, a below knee amputation, BK-amp, qualifies for 28% whole person impairment. So imagine that. A 25% loss of hip abduction strength, which is 10% whole person impairment, is almost half, half would be 14% of a below knee amputation. Okay, so we're going to be focusing on these particular joint motions when it comes later on in the program when we go through manual muscle testing procedures in the lower extremity. We're going to focus on testing hip abduction and hip extension and ankle plantar flexion and knee extension. And we're going to focus on those joint motions that the AMA guides consider to be the most important. And then in Chapter 17, for injuries involving the peripheral nerves, we use Section 17-2L. And peripheral nerve injuries in the lower extremity are going to be rated according to the same method described in Chapter 16 for the upper extremities. And in fact, we're going to actually use Table 16-11 for grading muscle strength of lower extremities, just as we use Table 16-11 for the upper extremities. Okay, so the procedure in Chapter 17 is going to be exactly similar or exactly the same as the procedure that we use in Chapter 16. So what would be some examples of peripheral nerve injuries that could involve the lower extremity? Well, I created an entire program on that. It's a 6-hour program. It is available for you. It's fully approved by the Division of Workers' Compensation for 6 hours. And I entitled that program Lower Extremity Impairments Due to Peripheral Nerve Lesions. So what would be just a couple of kinds of lesions to peripheral nerves that we could see in the lower extremity? Well, we could have a femoral nerve laceration, for example, in the case of an impaling wound, such as a stab wound, such as a contusion to the pelvis area. We could have tarsal tunnel syndrome, where the tibial nerve gets compressed right near the medial malleolus. That's a nerve entrapment syndrome. We could have drop foot due to common peroneal nerve injury. We could have a heel drop, and all different types of peripheral nerve injuries in the lower extremity. And I talk about that at great length in a different program. But for these types of injuries, we use Section 17-2L, and it's the same procedure that we use in Chapter 16 for determining impairments due to peripheral nerve injuries to the upper extremities. And I give you several examples of that as we go along here. And for those of you that have the PowerPoint presentation, I reprint or reproduce here again, just for your reference. I reproduce Table 16-11, and we're going to use this same table when we do manual muscle testing of lower extremity muscles in the case of peripheral nerve injuries. Okay, so there's a brief review of chapters 15, 16, and 17. And now that we've established the necessity of manual muscle testing throughout the AMA guides, we want to review some of the principles involved, first of all, with muscle physiology, so that we have a good understanding of how muscles work and what is actually taking place on the macroscopic and microscopic levels when we do our manual muscle testing. And then number 2, we're going to go over some of the general principles involved with manual muscle testing itself that will become important when it comes time to actually perform specific manual muscle tests on upper extremity motions, lower extremity motions, and also specific muscles as required in Chapter 15.